In the final days of the legislative session in Albany, state lawmakers overwhelmingly signed off on legislation regulating the relationship between pharmacists, commercial health insurance providers, and the middlemen known as pharmacy benefit managers. An element of the measure is a minimum standard dispensing fee for pharmacists when they fill a prescription, which is billed as setting a critical floor in revenue for mom-and-pop operations. But critics of the proposal argue this new requirement will drive up the cost of private health insurance in New York, and note that, in the face of opposition from unions, the language was amended to exempt collectively bargained health plans. To discuss the issue, we're joined in the Capitol Press Room studio by the measure's assembly sponsor, Cohoes Democrat John McDonald, who's also a pharmacist. Welcome back to the show, Assemblymember.
Great to be here.
Well, anytime we dive into the world of pharmacy benefit managers, I think it's important that we do some level setting for the listeners and, to be honest, for me. So, for starters, what role do PBMs play when someone goes to fill a prescription, and what is it about that status quo that you're trying to address with this legislation?
So they play a critical role. Basically, someone's got to coordinate the benefit between the health plan and the employer or the patient, right? In other words, you come to the pharmacy, what you don't realize is that in a matter of milliseconds, we're able to submit a claim, and the PBM tells us, yes, it's covered, no, it's not. And by the way, here's what you're going to get paid. So they play a very important role. The other thing that you don't see, though, and we don't see, and we meaning the individuals or society, is they are negotiating rebates in the background with the pharmaceutical companies. What we don't know is what happens to those rebates. We're told, and once again, understand, 3 PBMs control 85% of every prescription throughout the country. What we don't know is where does that rebate money go? And I've had health plans tell me that some rebates pass through to them, some don't. This gets into a much more complex conversation, which is a different day and a different dollar, which is vertical integration, because now you have insurance plans owning PBMs, owning health systems, owning providers, all in this vertically integrated network. It's all opaque. There's no transparency into what's going on. And I'm not saying that they're doing anything illegal. We're just basically saying we don't know what they're doing with the money.
But you brought up, though, on the floor that because of that vertical integration model, that the PBMs are paying their own pharmacies more than these other independent organizations.
They'll deny that. I remember several years ago when CVS was looking to merge with Aetna, we had a hearing, and I spoke specifically about the fact as CVS, you own your own pharmacies. I have a pharmacy 1 mile to the east and the west. What's the guarantee that you're not going to pay your pharmacies more than mine to drive us out? What I call predatory reimbursement. They denied it, but at the same token, case after case has come out. And, you want to look at a model, you need to look at the Oklahoma Attorney General's office. They will put out data all day, all night, showing how these PBMs are reimbursing their own member pharmacies more than their competition. We all realize that prescription drugs cost a lot of money. What people don't tend to realize is pharmacies don't set the prices. PBMs set the prices. They set what the reimbursement's going to be. And in the lack of oversight, we really don't know who they're paying what. The idea behind this bill, and it's kind of funny, there's a lot of attention spent on the dispensing fee, which, by the way, is the same dispensing fee as New York State Medicaid.
And that's $10.18?
Right. And that's what community pharmacies are actually asking for because of the fact that the reimbursement has been completely erratic. PBMs have been able to determine whatever they want to pay on generics, and they'll figure out whatever they want to do on brand names. There's some very noteworthy people that actually understand parts of this industry say, oh, my God, the dispensing fee is going up. Everything's going up $10.18. That's and we all know that. Everyone's focusing on the fee, but it's an equation. It's A plus B equals C. B is a dispensing fee. A is the actual cost of the drug. Currently, the system for most plans is this fictitious number, affectionately known as 8-1 paid, which is this magically increased price over the cost of the drug. And what happens is the PBM takes a discount off of that and says, here, pharmacy, you're going to do this because we think this is what your cost of goods are. What our bill does is says, you know what? Pharmacies for several years now, small mom and pops and large chains, have been submitting to the federal government their actual invoices to determine what's called a NADAC price. NADAC is National Acquisition Drug Price. the bottom line is it's the truest measure known to mankind of what the true cost of the drug is. So the critics out there, and we saw some Twitter sphere things going on a couple of weeks ago, no one's talking about the fact that the NADAC price is in many circumstances lower than what the AWP minus price is. So this is like a little push and a pull. Pharmacies actually make a lot more money on expensive brand name prescription drugs because of the difference between AWP and the percentage off. NADAC actually reflects the true cost. I know that sounds kind of perverse, but understand something. PBMs have no incentive to lower prescription drug costs, contrary to what they say. They make money on rebates. They make money on rebate aggregators. The more you push up the price, the greater the spread is, and that spread is what actually is where they make their money. It's very confusing.
But what safeguards are there either in this legislation or the oversight powers of the Department of Financial Services to ensure that if you are going to set this minimum floor, which in some cases is going to be dollars above what they're currently paying to some independent pharmacies, that's not going to be just passed along to the consumer? I mean, you're making this assumption, it sounds like, that there's multiple moving parts and that as a result, it's all going to work out in the favor of the consumer. Yeah. But that seems like a leap of faith.
In states that have done it, like West Virginia, there has been no attributable increase in cost to the drug benefit.
And do we have the same safeguards? Do we have the same oversight to ensure that this will play out the same way?
The one thing we did in the budget last year was we now require DFS to secure all the rebate information and any other associated fees.
Yeah, you said it's going to provide full transparency.
Full transparency. And I've been told by DFS, because I talk to them regularly, they actually put their survey out just about a month and a half, 2 months ago, with the hope that they would use it in this upcoming rate calculation for next year's spend. Let's think about that for a second. Rebates have been going on for 25 years. Mm-hmm. We have never asked for that information. It makes you wonder when these submittals are being done by the health plans with the assistance of the PBMs. And understand, some health plans are owned by the PBMs. Other plans can't stand their PBM. They just have to have a relationship with them. This information has been submitted either with or without the health plan's knowledge of exactly what the true net cost of the drug is. We need to focus on net cost of the drug. Mm. And pharma needs to be held to task too, which, to get back to DFS. DFS is going to be collecting that information not only from the insurance plans and the PBMs on the rebates and the fees, but also from the pharmaceutical companies so they can reconcile it. That's a great step forward if it's actually done properly. And according to DFS, they've showed me the process they're doing. It looks good. I'm hoping there's no interference. You know, we're dealing with
interference
by very large corporate companies. These are $100 billion a year corporations that are vertically integrated, that have a lot of resources. And quite honestly, they have a lot to lose.
Sure.
And they want to make sure they continue to gain. And once again, I deal with them. I work with them where we can. On this issue, if we're really talking about lowering commercial health insurance, which is what I hear from people, there should be a large focus on hospital charges, but there really should be a focus on what is the net cost of prescription drugs and how is that being used in calculation for premium, because I think we've missed the boat for 20 years.
Thinking about the other side of this equation, those independent small pharmacists who are cited as one of the reasons for doing this so that they can have a more reliable and higher revenue stream.
We call it stable.
Sure.
It's stable. It's not going to be higher. You were actually getting more money on expensive brand name drugs, just to be very clear. So there's going to be a reduction there. However, there'll be a consistent dispensing fee on any prescription, whether it's $1 a cost or $1,000 a cost. The pharmacist will still make $10.18, give or take.
So this is being done in part to stabilize them with a stable fee. But looking at the number of independent pharmacies in New York State, we see that New York has a larger share of independent pharmacies than any other state other than North Dakota, and their ranks are growing, whereas it's those chain pharmacies that seem to be the ones going out of business.
And by the way,
is this necessary from that perspective?
The chain pharmacies are supportive of this too.
Sure, but from the independent pharmacy perspective, do they need anything to actually support them if their numbers are growing?
That's a fair question. The numbers are growing, but it's a little bit deceiving because, first of all, a lot of pharmacies are splitting into two. pharmacy I work at, Maris Pharmacy. We are actually replicating ourselves because there are long-term care contracts. So from the distance, you say, oh my God, there's more pharmacies. Well, a lot of pharmacies are running a retail business and they're running a long-term care business, but they need to have ID numbers separate and apart from both. And I will tell you that other states actually ban chains from actually being in their states. And I think North Dakota is one of them. But in New York State, we are very diverse. There are many pharmacies that are specific to cultures, particularly in New York City. But that whole long-term care thing is not being included in the conversation, which I think people forget about. And yes, I will say this, Medicaid stabilization, the Medicaid reimbursement has led to a slight increase of pharmacies reapplying to be in the Medicaid program because actually before, when the PBMs ran it, they ran them out of business.
I mentioned at the top that the health plans that serve unions were carved out of this because of opposition from organized labor. It seems like that was solely in response to their concerns. So is there a case to be made for giving commercial health insurance plans who say, hey, this won't be good for our members, the same ability to opt out?
I don't think so. Senator Skoufis and I worked very closely on this bill. We met with the labor groups. I don't agree with their logic on it.
So you think it would be good for them and their plans?
I think it would be great for them. And there are self-funded plans that have saved hundreds of millions of dollars by actually having a more transparent model. This is no different than Mark Cuban's Cost Plus program. That's what this is. And by the way, the FTC, under both Joe Biden and Donald Trump, have ordered these large integrated entities to start implementing this model that we are pushing now across all their lines of businesses by 2028, 2029. Ordered them because of the fact that senators and House of Representatives on both sides of the aisle in all 50 states have called for this. The FTC has done enough investigations. They see what's going on. They see that there's arbitrary reimbursement going on. It's not fair by any stretch of the imagination. And at the end of the day, all it's been doing is driving up drug costs. It doesn't make sense.
That brings us back to that initial point you made, which is the vertically integrated nature of these companies. And it is a bear to get our arms around. But is there a case to be made for the state to try to either break them up or do something to be more aggressive regulatorily?
There's a couple different things. First of all, we should be more aggressive regulatory. I've made many requests to the Attorney General to take a harder look at this.
They've just said no thank you?
No, they're actually doing consideration. They're trying to figure out what it is. I've connected them with leading states like Oklahoma and West Virginia who actually are leading the charge. And driving costs for commercial health insurance is primarily dictated by the prices that hospitals are requesting. And that's a different discussion, a different day. Pharmaceuticals, at the end of the day, everyone throws their hands up in the air and says, it's an issue with the PBMs. And then they bring up the infamous 340B, which nobody understands, except for maybe three people. There's some real problems in that system, but it keeps driving up the cost of drugs. And at the end of the day, that's a problem.
And you can hear more about the 340B issue in the Capitol Press Room archives at capitolpressroom.org, wherever you download your favorite podcasts. But unfortunately, that's all the time we have for this conversation. We've been speaking with Assemblymember John McDonald. He's a Cohoes Democrat who's also a pharmacist. Assemblymember, thanks so much for making the time.
Thank you, David.
Support for the Capitol Press Room comes from O'Donnell & Associates, a public affairs firm providing strategic guidance to businesses and nonprofits on navigating policy and regulatory issues. More information is available at o'donnellsolutions.com.